Thanks very much, Mark, for the invitation to speak here. I'm Scott Norton, a dermatologist at Georgetown, and for the last year, I've been the acting dermatologist at Children's while we're waiting to hire a full-time dermatologist. I find that the patients that seem to get referred very often from the general community are those kids who are itchy. So I decided to take the two itchiest conditions, or two most common itchy conditions, and we're going to have the tale of two itches. It won't be the full volume of that. We're going to do more of the classic comic book version, but we're going to talk a little bit about childhood eczema and about itchy scalp. And let me just say that A, I regret that I have no financial conflicts of interest, and B, I'm going to discuss some off-label uses of medications. So we're going to divide my 30-some minutes into a 20-minute guide to eczema and a 10-minute guide to itchy scalp. And I think that very often this is the approach that we take. This shows my night call here, the housekeeper answering the phone saying, "That's right, scratch it like mad." Useful, but we can try some other options as well, and we'll go into that. Now, the first thing we'll talk about is mostly about what is commonly called eczema, but I want to refine the definition and the diagnosis a little bit here. So what is eczema? What is dermatitis? Now, to a dermatologist, these are interchangeable terms. They often make dermatologists cringe when we just hear we have a patient with eczema or a patient with dermatitis, because there are many types of eczema and many etiologies for that. I think clinically you can call something an eczema or dermatitis, again using the terms interchangeably, if it meets these four clinical criteria: three that are signs and one symptom. The three signs are that it's scaling, red, and either vesiculating or oozing. And certainly the symptom is that it is itchy. So if something meets those criteria, you can certainly call it an eczema or dermatitis, but ideally there'll be some sort of adjective before that term, because, like I said, we have many, many forms of eczema and dermatitis, and to a dermatologist, the word eczema standing alone is too nonspecific. So what I would like to request is that you just refine it one notch and say that we're talking about childhood eczema or atopic dermatitis. And what is the definition for childhood eczema or atopic dermatitis? Well, that's been debated, and many people have their own definitions, and I suppose that in clinical practice we really don't even go through necessarily a checklist of criteria. Does it meet three major and X number of minor? We just essentially look for this stereotyped constellation of an itchy kid with the typical morphology and distribution of the lesions, primarily on flexural surfaces, that there's a history that it's chronic. It just didn't come up for the very first time over the weekend, and it does have a remitting relapsing course on its own and a remitting relapsing course while treated as well. And generally there's a personal or family history of other conditions in this atopic triad, to include atopic dermatitis, asthma, and rhinitis, allergic rhinitis. There are a number of minor criteria that one can look for. I'm not going to go into detail on any of these, but that's the points about the definition of atopic dermatitis and the terminology. I'm going to touch on something called the hygiene hypothesis that most of you, I hope most of you have heard about, but essentially it's the notion that in this era of increased hygiene that we have in developed countries in the West, that part of our immune system feels all dressed up with no place to go. It's all ready to fight off bacterial infections, parasitic infections, but in the absence of those, it's got to find something to do, and it seems to elevate and accentuate a lot of allergic responses. The way that this hygiene hypothesis was first generated was from the observations that we are seeing this increasing prevalence and incidence of these allergic conditions. And some fairly simple epidemiologic observations are made, is that these conditions are more common in Western countries. They are less common in kids who live on farms, the assumption being that they're exposed to more antigens, while they're there, more infectious organisms, more bacteria. These conditions are less common in kids who have pets at the house. Again, the assumption is there's exposure from early childhood to more antigens and possible pathogens. And then one more item, as the dad of only boys, I appreciate this. It's less common in younger kids, especially when the older kids are all boys. The assumption being that boys are a less hygienic species than girls. So from those observations, and those have been well documented, we now generate this hygiene hypothesis of too much hygiene and leading us to the susceptibility for more allergic reactions. And so to put this into what I call the simplified view of the immunology of atopic dermatitis, we have intrinsic, perhaps hereditary, and extrinsic factors, and they enter this black box of the child, and it comes out as atopic dermatitis. If we want to get down to the nitty-gritty, the immunologic pathway looks something like this. So that's all I want to talk about with the basic science. Actually, it's not all I want to talk about with basic science. It's all I will discuss about the basic science of the immunology of this. However, there are some interesting observations and reports of the last decade or so, and this one was in New England Journal as a review article just a few months ago on filaggrin mutations. And filaggrin is a protein that's found in the uppermost part of the epidermis, just at sort of the edge of the stratum corneum. And it appears that there are many genetic polymorphisms in filaggrin. And most of them still allow the skin to do the job, but some of these polymorphisms seem to lead to this cluster of conditions that you see repeatedly in your patients with atopic dermatitis. So they have atopic dermatitis. They also have Ichthyosis vulgaris. And you can just sort of think of that as a familial or congenital dry skin. They typically have hyperlinear palms, and they often have Keratosis Pilaris. Let me just run down these last three for you here. So Ichthyosis vulgaris, you can see the clinical image shows what we call the cracked porcelain look, most prominent on the anterior shins in the wintertime. A lot of your patients will just say, oh yeah, I've got dry skin, or my son's got really ashy skin, and just take the skin and sort of manipulate it a bit, and if you get this old glazed, cracked porcelain look on the legs, it's a good chance that they have Ichthyosis vulgaris as part of the genetic component here. And you can see in the palms that we have this hyperlinearity. You can all look at your own palms right now, and those of you who have an atopic diathesis will find that you see a lot of these lines, particularly on the thenar eminence. And those of you who don't have any atopic dermatitis, those lines are prominent in this picture as a cross-hatching, really aren't very prominent. And so when you're evaluating a patient or the family, other children in the family with atopic dermatitis, if you see these features, the hyperlinear palms and the Ichthyosis vulgaris, there's a chance this child also has other aspects of these filaggrin mutations. Another one that's very common is Keratosis Pilaris, which is this common, harmless, inherited accumulation of keratin around the hair follicles, typically on the extensor surfaces, and typically very symmetric. You see kids with this all the time, and you recognize that it's probably one of the world's least consequential medical conditions, but yet it can cause a lot of distress, typically to moms and grandmothers, not necessarily to the child. But the diagnosis is fairly easy to make. These monomorphic, uniform, tiny, follicular-based scaling papules, feels almost sandpapery on the backs of the triceps, but you can also see it on the anterior thighs and buttocks. And there is a facial variant that is called Keratosis Pilaris rubra faciae, meaning red face. So I've seen maybe 2 kids a month who are referred for that. They have pretty standard KP otherwise, but when you see that on the cheeks where it's sandpapery and dry and gets a little red, that's the facial variant of KP. Common in kids, it usually resolves maybe by 8 or 10 years of age, and little moisturizers and some cortisone can be applied to that. You don't have to worry about that being some facial cellulitis. If they have the KP elsewhere, go ahead and treat that, please. And how do we treat that? Well, first of all, it's a genetic disorder. There's no true cure for it, and there's no particular therapy that's been found to be universally helpful. These are some off-label uses here, but ammonium lactate or lachydrin, amlactin, that is something that you can try. Salicylic acid, there's a new version of that. And I don't have any conflicts of interest with any of these companies, but your patients usually like to know a name. And I always do advise that if there's a CVS equivalent or generic equivalent of a generic, please go ahead and get that. But salicylic acid, there's a moisturizer called CeraVe SA salicylic acid. You could give that a try. Urea, there's different strengths, and some of them require a prescription. Gentle steroid creams if there's a lot of erythema and maybe some pruritus associated with it. And then a couple things that a lot of patients try is the retinoids and mechanical debridement. Those will usually just dry the skin and irritate it a bit more than is necessary, so I recommend not following that approach. There have been some reports about using lasers. I've talked with Dr. Rubin, who will be speaking next, and she says that yes, although there are a few reports on using this, all those reports show minimal to no effect, and of course, it's unlikely that an insurance company would cover laser treatment for KP. All right, eczema variants. There's a couple variants of childhood eczema that we see regularly, and I just like to help you define those in your own mind. There's follicular or papular eczema, most commonly seen in black kids on the anterior abdomen as these little monomorphous, slightly hypopigmented papules. They might have a more typical atopic dermatitis elsewhere, but this is a common feature, and again, moisturizing and a gentle cortisone will help here. This is rarely as itchy as the eczema on the extremities. And here's another example of a young lady who has this even all the way up onto her pectoral region, where you can see all these very fine, uniform papules here. Perfectly regular distribution on hair follicles. It often turns out that because these follicular eczema regions aren't necessarily itchy, the major complaint with them could be the hypopigmentation. And so again here, I think if you moisturize and use just some gentle cortisones, it may help even out the discoloration. We rarely see this variation in older kids, so it seems that kids will outgrow the follicular component of atopic dermatitis. Now, you're all aware of the textbook definitions of atopic dermatitis emphasizing the flexural distribution of this disorder, but I do want to talk about another described variant that goes under the name frictional lichenoid dermatitis. And what I want you to do on these kids is look at their flexors. There's nothing involved there, but look at their dorsal forearms and elbows. And on the extensor surfaces, we see that there's been a lot of rubbing and itching, and you get this chronic thickening of the skin that is known as lichen simplex chronicus. Although in the textbooks this is called frictional lichenoid dermatitis, I think a better name is extensor lichenoid dermatitis. And so actually when you do look at your kids, you may have already diagnosed them with atopic dermatitis. That is correct. This just seems to be a different morphologic variant where the distribution of the lesions is on these knees and elbows. This is not psoriasis. The skin gets a very thick, almost corrugated look on the knees and elbows. And you can see these very fine papules on the backs of the hands that almost look like molluscum there. They're, again, discrete, dome-shaped, very itchy papules, and they can coalesce. So this would be in the differential of molluscum contagiosum, but if you see it symmetrically on these surfaces, think of it as this extensor lichenoid dermatitis. Treat as you would for atopic dermatitis. And then the third variant is juvenile plantar dermatosis, which you see on kids maybe under the age of 10 or so. I'd say maybe 4 to 8 is the typical age of this. This is a shiny, thickened keratoderma, thickening of the skin on the forefoot there. Notice how sharp it starts on the forefoot, and it's really got this, again, almost like a varnish-like sheen to it. There can be some deep and painful fissures there, and it can be itchy. Those kids don't have Tinea Capitis. Check to see if there's any evidence of tinea on the heel, like dry skin. Check to see if there's any evidence of tinea between the toes, like a lot of macerated skin. You won't see it. These kids generally have a history of mild atopic dermatitis, and the key thing is they have a history of stinky feet. These are kids who are wearing the same pair of sneakers all day long, running around. I mean, that's fine and healthy, but they are kids with mild hyperhidrosis, and they really sweat, and their sneakers really stink, and their socks stink. And I just ask the kid if he has stinky feet, and everybody in the room, the parents will laugh and say, "Oh yes, it can clear the house." But this is like an atopic reaction, probably to the patient's own sweat. And for these kids, if they can change their shoes daily, change their socks in midday, go barefoot or in flip-flops at home, maybe some Z-Sorb powder in their shoes, and a little bit of cortisone cream, and they'll get better. But you don't need to work them up for Tinea Capitis. Patients often complain of pigmentary changes, and there's a whole list of pigmentary changes you can see in kids with atopic dermatitis. We'll run through a few of these. So post-inflammatory hyperpigmentation, particularly, again, in dark-skinned people, and particularly if they have this extensor variant, in some families, the pigmentation is more significant, is regarded as more important than the fact that the kid is sleepless at night, falls asleep during school, is constantly scratching. But this will clear. This is not scarring. It is not permanent. You need to get the dermatitis under control, get the lichenification reduced, and with time, this will return to a normal skin hue. It is frustrating to the individuals, and that answer that it may take several months once we get things under control is certainly not what they want to hear, but you can definitely provide some reassurance that it is not a permanent part of this. Now that's darkening of the skin. There's a couple forms of lightening of the skin, the most common of which is Pityriasis Alba, that just translates to fine, branny, white scale. And this is most common in kids of a medium complexion. And just to generalize, light-skinned blacks, Asians, and darker-skinned Hispanics, we see this in the kids very commonly around the face and around other areas where they may have had mild atopic dermatitis. It's not so common right on the flexors on these kids, but it seems like these kids have sensitive skin, and it could be something as simple as drooling at night, or maybe having some milk from the bottle on their face, or getting a windburn, or a little bit of soap left on their face after washing. And the skin heals with this very finely textured, slightly dusty, whitish hue. The margins are not sharp, and this can be treated, with just reassurance and no particular treatment, and that's fine for many families. Reassurance. Moisturizers certainly are essential. Consider some very mild hydrocortisone creams, and then sunscreens, which will help prevent accentuation of the dark-light differences during the summer months. Okay, a lot of families really worry if this is vitiligo, and there are some strong cultural concerns about vitiligo in general. In some areas, in India, for example, many people are rendered ineligible for marriage if they have vitiligo, and that's probably from the historic concept that hypopigmentation of the skin is leprosy until proven otherwise. So I'm jumping into a couple other areas there, but the parents will want to know if this is vitiligo. So I do bring this up with every family and tell them that Pityriasis alba is not vitiligo, and it won't turn into vitiligo. And some of the ways that you can convince yourself and convince the family is that vitiligo almost always has sharp borders. Vitiligo has at least some areas, if not most or all, that are depigmented. I mean, they're just as white as snow. There's no pigmentation whatsoever. In P. alba, we do have hypopigmentation, where there's still some color there. These kids have a history of eczema or some sort of irritation that they had on their skin. Vitiligo has no dry component to it, no fine scale to it. And then in vitiligo, typically there's a family history of vitiligo or other autoimmune diseases, as we learned in the last lecture. And so you can just run through a checklist like that to reassure the family, because that's often the underlying concern of many families. Now, unfortunately, severely inflamed atopic dermatitis can lead to complete depigmentation, as we see in this image, and this is going to be very slow to repigment if it repigments at all. I've only seen a few kids who've gotten to this point, but you just go ahead and you wait and see, but at least you can reassure them that this is not vitiligo. Now, another question that's common is, does eczema cause scars? The answer is no. True atopic dermatitis will not cause scars because this is a condition that inflames only the epidermis, which is above the dermis where the collagen is, where scars form. But if there's secondary bacterial infections that go through the epidermis into the dermis causing eczema, or if there's deep excoriations, you can damage the collagen and get some scars. And again, scars are permanent, discoloration is not. Relationship with pathogens. It's a fast-moving field right here. Some of these things you see regularly, and that's, for example, impetiginization. So don't hesitate to culture these kids and to begin some sort of treatment for staph. You can check with your lab or your ID folks about what the likelihood of it being MRSA or MSSA is. But we do expect that almost all atopic dermatitis has some staph that's colonized it. Colonization can, in many cases, upregulate and inflame the dermatitis without actually causing a true infection. But if you are seeing pus and oozing and active weeping, then it's worth considering this as infected and then go ahead and treat per your particular protocol on impetigo. You may consider nasal culture to look for MRSA and then do some mupirocin treatments as well. I put down topical steroid there, which seems in many ways counterintuitive to treat a kid with impetigo with steroids, but in the couple studies where that's been done, where the kids have been treated with steroids alone, once you get the inflammation under control, the impetigo seems to go away because it's really just a surface location of the staph. So not that I recommend you put the patients on high-strength topical steroids at the time. I do on occasion, but I certainly will use emollients as well to try to help get that the epidermal barrier reestablished. Now, here's another condition that we learn about in medical school and in residency, and we think of this with, as quite a dangerous condition, and indeed, historically, eczema herpeticum has killed kids, but you know what? I'm seeing probably 1 to 2 cases of this every week now, and those of you in emergency rooms may be doing the same. What we have at eczema herpeticum is the unchecked replication of HSV, herpes simplex virus, usually HSV1, on the skin of these kids with atopic dermatitis. These kids have a couple strikes against them. One, there's simply the mechanical disruption of the epidermis. The skin is dry and fissured and all these micro openings there. The second thing is the person is constantly scratching. So there's the real prospect of autoinoculation of the HSV from one site that's initially colonized to the rest of the body. And you can see this also on parts of the body, on parts of the skin that do not have any active atopic dermatitis. It can get in there probably through these microscopic, unnoticed cracks and fissures in the skin. So that's a couple risk factors. The other one is that people with atopic dermatitis, whatever the complex of immunologic derangements is, these kids have a extreme susceptibility to several pathogens, to HSV, to molluscum contagiosum, to various types of staph, and to vaccinia virus that's used in the smallpox vaccination. And so when you get these kids, they look like they have these uniform either vesicles or dried up crusted vesicles that are all about 2 to 3 millimeters in diameter. They're all look exactly alike, and they're typically, I see them a lot on the face and on the extensor forearms there. And the way that you approach these patients is you must get laboratory confirmation of the diagnosis. You may not have access to these at your facility, but this is certainly worthwhile of an emergency room or today consult to dermatology or allergy. Dermatologists might get a sank prep right there, but in most hospital labs, getting a PCR or direct fluorescent antibody test is the most rapid way to establish the diagnosis or the presence of the virus there. Cultures and HSV titers, they may make some sense in an armchair capacity. If you have unlimited amount of time, they are not useful at all in the urgent setting. If you want to go ahead and get those, that's fine, but please go ahead and make sure that we get some sort of rapid diagnostic test done as well. Treatment is with acyclovir, often with admission and intravenous delivery of the acyclovir, appropriate isolation, emollients, again, to help restore the surface of the skin. And as I mentioned in the previous slide, indeed, you could probably use topical steroids to help get the inflammation under control, but that's not for an outpatient activity. And then, of course, eczema herpeticum can recur in these kids multiple times. We do see it multiple times. Okay, molluscum on the antecubital fossa, very common condition. I'd say most of the kids who have widespread molluscum have atopic dermatitis, and again, there's these micro portals of entry to the skin, and there's this fundamental genetic susceptibility to some viral diseases like this. This is a very difficult condition and frustrating for all of us. Some of our textbooks say that we don't even need to treat molluscum. I think if you have a kid who's got atopic dermatitis and they're likely to get hundreds of them, you really need to go ahead and make an exception to your usual policy of not treating and start to treat these kids. Unfortunately, there's not an ideal treatment. Try to get the atopic dermatitis under control. Try to get the scratching under control. In the office, there's a handful of things that you can use listed here, and later you'll get them in your either videotapes or handouts. And then at home, you can also have patients use some of these items. And again, these are off-label uses of these products. Okay, hygiene facts. Run through a few things here. Many of you have heard to try to discourage the families from bathing these kids. That was the old notion. I personally think that little kids love to be in the bathtub, and if you can get them in the tub and let them calm down and relax and hydrate the skin, then do so, but use either no soap or very gentle soaps and then moisturize them right away when the skin is wet. I think a lot of parents like to hear a doctor tell them that you don't need to reduce to one bath a week because that may be the most fun an itchy kid has during the day. The bleach baths, I'm going to go over that in a second, and here we go. So bleach baths, as barbaric as it sounds to all of us on initially hearing about it, it has been shown in multiple studies, and at NIH now, it is considered the standard of care for the kids with moderate to severe atopic dermatitis, where twice a week you go ahead and have the kid take a very dilute, a bath with very dilute, common household bleach. The kids soak in the tub for 5 or 10 minutes. There's no reason to use any soaps along with this. And again, we'll have this on the handouts that are coming to you later. Moisturizers, emollients, humectants, and lubricants. Some dermatologists and FDA folks will split hairs on what these are. Essentially, use anything you can that's got a good greasy texture to it. Apply it when the skin is damp. When you apply grease to dry skin, it becomes greasy. When you apply grease to wet skin, it actually can help retain the moisture. The grease in itself does not moisturize the skin. You have to have some water on there to begin with. Now there's a natural emollient or lubricant that we have in our skin called ceramide, and that appears to be deficient in kids with these filaggrin mutations, kids with atopic dermatitis. There are a couple moisturizers that are out in the last few years, CeraVe, which was developed by the Derm Department at UCSF, and Cetaphil Restoraderm, specifically Restoraderm, that have the ceramides added to the emollients under the belief that the ceramides will be absorbed topically. And I think the final chapter is not written on this, but I am using these preferentially over all other moisturizers now. And one last item that I've noticed in my practice at Children's is a lot of families have the practice of scrubbing kids with washcloths. And even though the moms will say that they take the gentlest soap, the Cetaphil or Dove, they put on the washcloth and they scrub the kids. And it's a genetic thing. It's autosomal dominant. And actually, I have a protocol. I'm going to go and look at that. But it does seem to carry down through maternal side. It's an X-linked dominant disorder. But get the families to stop this notion that you've got to scrub away at the eczema. Atopic dermatitis is not dirty. These kids are often the most hygienic kids you have around. So please dispel the moms of this notion about scrubbing. Itch control, there are 4 types of topical anti-itch agents that are readily available to you, and I use these all the time, but probably more importantly is to notice the bottom line, and that's don't use the topical Benadryl because roughly 10% of kids will develop an acute allergic contact dermatitis to topical Benadryl, and don't use topical neomycin or Neosporin because probably 15% of kids will develop an allergy to that. So please remove those from your recommendation lists. And steroid phobias. I don't think I'll be able to dispel that in you. Dermatologists always feel much more comfortable using stronger steroids. One thing that the parents will ask you is, I don't understand the numbers. I had hydrocortisone 1%, but now you're giving me this fluocinolone 0.05%. Isn't the hydrocortisone then stronger? And the analogy that was passed on to me is just to use this thing about numbering cars. You know, which one is a more powerful car, the Pinto 1000 or Ferrari 430? So use that analogy with them. Calcineurin inhibitors. Protopic and Elidel, there's a black box warning on these. These were developed as a much-needed steroid-sparing agent to get rid of some of these side effects of the steroids. Elidel and Protopic are good. A lot of the insurance companies won't pay for it, but the black box warning says that this is a mild immunosuppressant, and there have been increased cases of lymphoma with this. Let me just see. Possible association with miscellaneous lymphomas. A tighter analysis on this found that the lymphomas, some were B cell, some were T cell, and different types of lymphoma. So etiologically, it doesn't necessarily follow that it's these creams and ointments that are the cause. So dermatologists still feel fairly comfortable prescribing these. And conclusions, if your atopic patient is not improving with the treatment as you expect, check compliance. Maybe there's another diagnosis. Maybe there's a bacterial infection going on. There are some cases of contact allergy to the preservatives or to the Benadryl topically or to the steroid itself. You can change the regimen and then refer to dermatology or allergy in that case. I'm going to talk just 3 minutes on this last subject of the itchy scalp. And here are some of the entities that can cause an itchy scalp, but the ones that are most common in our practices are right here. Irritant contact dermatitis, scalp ringworm or Tinea Capitis, and seborrheic dermatitis. So Tinea Capitis, examine the kids and really epidemiologically, if you have a black child, African American child, they are far more likely to get Tinea Capitis than Asian kids or Caucasian kids. There's various reasons for that, but certainly the black child with scaly, itchy scalps, on the exam, if you have posterior cervical lymphadenopathy, if there's a dusty scale and other kids in the family with that, then you're talking Tinea Capitis there. We often do the potassium hydroxide preparation, but for you, it really should probably be just a fungal culture. Here, when you see kids that have this kind of dusty Tinea Capitis, black child, posterior cervical lymphadenopathy, scaly scalp, itchy, and patchy hair loss. The best way to get the culture done on this, if you can get some disposable toothbrushes, and the children's, we certainly have those, and we just wet the toothbrush with some normal saline, scrub the scalp, and then break off the toothbrush head and send it off to the lab. I want you to do that because too often we get in these situations where we presumptively start some antifungal treatments that aren't working, and they get sent to the dermatologist where the kid's been on itraconazole for a week and ketoconazole for a week and griseofulvin for a week, and it's very difficult for us to make that diagnosis and frustrating for the family because this can go on years if we don't get the diagnosis established in the first place. Okay, irritant contact dermatitis. Again, demographically, this applies mostly to teenage black girls, and your homework assignment is to get this video documentary, Good Hair, that Chris Rock put out. In a nutshell, Chris Rock was wondering why his beautiful daughters were in tears when they were going off to a party, and when they were dressed up looking beautiful, and they cried out, "Dad, we don't have good hair." And so he did a little inquiry that's not a comedy, but into the hair care industry. And just like this child who's getting relaxers on her scalp, many of the items that a lot of our young ladies like to do to make their hair look fashionable and stylish actually are irritating to the scalp. And this is the sort of thing that I see. And when kids put weaves and braids and extensions on these, you can get this where it just accumulates and accumulates. And then finally, with seborrheic dermatitis on the scalp, you can treat that with low-potency corticosteroids and with the topical antifungals. The relationship between the fungal organisms and the seborrheic dermatitis is not completely worked out, but we know that treatment with both of these items, a little cortisone and a little antifungal, will do the job. And with that, I'll conclude. The specific question, whether HPV infections are more common in kids with atopic dermatitis, the answer is no, or at least not with any clinical significance. It really does seem to be just a handful of viruses, molluscum contagiosum, and vaccinia, which are both pox viruses, and HSV1 and 2. And that's probably because of an error in natural antimicrobial peptides in the skin of the kids with atopic dermatitis. And HPV does not seem to be part of that whole constellation of issues.
Dr. Norton, Dr. Norton, how do you feel about, after the bath for remoisturizing the skin, the use of Vaseline?
The use of Vaseline or plain petrolatum is fine. It's probably the least expensive moisturizer that's out there. You can get a CVS brand for, I think, $2 for about a 6 or 8 ounce container. So it's economical and it works. But again, you have to put it on really wet skin in order to get it moisturized. Putting it on just dry skin doesn't actually do anything as far as trying to get moisture back into the skin. So if a family wants to do that, it's fine. I'd rather have them use that than buy some more expensive product with a fragrance or moisturizer, fragrance or preservative.
Thank you.
Question for Dr. Norton. Can you comment on the use of Elidel or Protopic for vitiligo?
The question was on the use of Elidel or Protopic for vitiligo, and I'd love perhaps to have a chance next year to talk about vitiligo, which is again one of the commonly referred conditions. But as of today, we really have no approved treatments for vitiligo, and there really are very few treatments that have shown a fair amount of promise. Nevertheless, some of the immunosuppressants like the topical corticosteroids and the Elidel and Protopic do seem to have some efficacy in slowing down or perhaps reversing vitiligo. I wind up treating probably most of my vitiligo kids with either Elidel or Protopic. I often just have them use a corticosteroid on one side of the body and Elidel or Protopic on the other side. Protopic is stronger than Elidel, so generally I prefer that. But again, a lot of insurance companies won't pay for that.